Hello.
आखिरी
Thank
2
you so
सेकंड की
much
बात है, सामने
to the
देखो।
AIOS Scientific Committee and ELCON for giving me this opportunity. And I'm going to present a hyperwit deferred surgery cases. So why hyperwit? Slides not moving. Yes. Thank you. Why hyperbit? So what are the main challenges or concerns while doing a vitreoretinal surgery or the performance of cutter in a smaller gauges? As we all are moving away from the large incision surgery in all segments, be it cataract or retina, so vitreous removal, fluidics instability, complex surgery are the basic challenges which we may face while doing surgery in a smaller gauge, because if the smaller gauge is inefficient vitreous removal is there, then that can increase the surgical time, that may lead to increased risk of complications as well, and that will lead to increased difficulty in managing complex cases, and especially if the instruments are malleable, then approaching the peripheral retina can be difficult in such cases. So here comes the role of hypervit, that this system actually makes us comfortable in operating even in the smallest gauge for even the complex cases, because of its versatility, efficient vitreous removal, and superb fluidic stability. And the design of the tip is bevel so that the opening or the bore of the cutter or the mouth of the cutter is very close to the surface of the retina, and then we can approach all the membranes even closer to the surface of the retina, even without touching the retina or damaging the retina. And it gives actually the 47% more closer proximity in a 25 gauge cutter, and 40% more closer proximity to the surface of the retina, to the cutting bore of the vitreous cutter. And the vitreous removal efficiency is also increased much more in cases of hypervit, because it it actually works in double pneumatic blades, and the port is always open, so the vitreous flow rate is always high, up to even 90%, and in cases of if we compare with the 10,000 cut rate, up to even 44%, and in 27 gauge also the efficiency is much better, up to 26%. And why this is? Because there is a dual pneumatic cutter, and that leads to the superior fluidic stability also. So this is the actual design, and that leads to the even peak traction force is very less, and this design also reduces the dead recirculatory flow zone inside the tip of that cutter probe, and that's why the vitreous aspiration removal is much faster as compared to the normal this vitrectomy cutter. So here we are coming to our recorded cases. This is a 360-degree giant retinal tear, and whole of the retina is detached completely from the periphery and folded upon the disc. And this was one-eyed patient, and vision was just perception of light. So we operated this patient with a 25 gauge hypervit system, and the whole that vitreous is quite efficiently removed with a high cut rate, and aspiration flow rate is very efficient and fast. And once we have removed all the vitreous, we have to actually unfold this folded retina, which is just folded like some folded bread or something like that. And then just after removing the vitreous, we will just, and this cutter is so efficient that even nowadays we are removing IOLs or foreign body also with the help of cutter without using any forceps. So now here comes the unfolded retina, and we have unfolded the retina and then put PFCL over it to stabilize the retina, and then we will complete the residual vitrectomy or peripheral vitrectomy, and then that peripheral uncut zone or torn zone of the retina should be removed to avoid future development of neovascular glaucoma or anterior segment neovascularization. And after finishing the complete vitrectomy, we have to do 360-degree laser barrage all around nice to settle this retina. Yes, here comes the that 25 gauge curved laser probe that approaches the periphery very nicely and efficiently, and we can finish off the laser in very less time. After doing laser all around, since it is a 360-degree detached retina, we have to do direct PFCL silicone oil exchange, because if we go for air, then retinal flap might come again and slip again, and that will lead to difficulty in settling the retina. So we have done partial FG filled with the silicone oil partially, and then we switch on to this comes the silicone oil, and now we will be switching to direct PFCL silicone oil. This is the direct PFCL silicone oil exchange. And in Elcon Constellation machine, there is a dual aspiration system also. With a single foot press, you are injecting silicone oil and aspirating PFCL also. So that is excellent function available in this machine, and that works very well and makes our job very easy. And here comes the end of the surgery, and this patient recovered 6/6 vision in a week's time under silicone oil, and excellent outcome. This is my other surgery. This is optic nerve head pit. So we have planned a scleral patch grafting into the optic nerve head, and I am inducing PVD. It was not coming with the cutter, so we have used this pick. This is a pick ready-made available from Elcon only. So this pick actually nicely dissects the cortical vitreous and separates it from the surface of the retina, and that helps us in getting PVD induction very easily in complex cases. And after removing PVD, we have to complete the vitrectomy in such cases, and then we are harvesting a scleral partial thickness a scleral graft to be put in the optic nerve head pit. And yes, now dissecting the sclera to take a patch to be placed over the optic nerve head. Here comes the max grip forceps. We will take this forceps. And remember one thing, to remove that trocar cannula system, because through the cannula, generally that scleral graft doesn't go inside. So we are going on the bare sclera and just snugly fitting in the optic nerve head pit, and that gives us excellent outcome in cases of optic nerve head pit leading to maculopathy. This is a case of foreign body, and we have removed this foreign body just with the help of vitrectomy cutter only, and no forceps was needed. This foreign body traveled inside the retina by piercing the cornea and lens, and we have put one suture, and then pars plana lensectomy was done, and then vitrectomy was done, and through the vitreous, this is the floating foreign body which was inside the eye. And since it was a small foreign body, but even a bit larger foreign body we are removing just with the cutter. Just switch off the cutting of the vitrectomy cutter and use the suction. It holds very nicely any kind of foreign body or even IOL, and we are not at all using any forceps for such foreign body removal inside the vitreous, from the vitreous cavity. PVD is being induced, and then vitrectomy has been completed in this case. And all these cases have been done on 20,000 cut rate with hypervit system. Yeah, sir. Just 1 or 2 minutes more, sir.
Since we have one more case lined up.
Yes, sir.
And Dr. Santosh has given us
here comes the foreign body, and now from the opposite hand, there is a magnet coming out, and this magnet puts this external magnet, and the foreign body comes out, and now that leads to the end of the case. This is the last case I wish to show. This is subretinal band removal without creating retinotomy, and this is actually a suprachoroidal surgery. So we haven't entered the vitreous cavity. I have put a trocar cannula system, and I am going through the external route behind the retina. My forceps is behind the retina, and it is actually grasping the subretinal membrane, and here comes the membrane, and it comes out through this system. And why this valve system maintains the excellent things. This is last case of ROP, stage 4 ROP. This case is actually very small eye and challenging cases, but again in such cases also this vitrectomy cutter helps a lot to remove the membrane without putting any traction on the retina, and we can get very, in fact, majority of the stage 4 ROP cases we are doing vitrectomy, and we are getting excellent outcome. And now many of our operated stage 4 babies are grown-up kids, and they are seeing very nicely. So for stage 4 also, these cutters helps us doing nice dissection of the membrane without putting much traction on the retina and creating any traction or break on the retina. So completing the case successfully. Thank you so much to all of you for your kind attention, and thank you for the